I want to go over a really interesting study that I was lucky enough to attend the presentation that was initially given before publication at the Society of Critical Care Medicine meeting. And the question was, does a single dose of ceftriaxone in patients who have traumatic brain injury prevent early ventilator-associated pneumonia? This was a multi-center, randomized, double-blind, placebo-controlled, assessor-blinded superiority trial. That sounds like a lot, but I'll kind of go through it here in a second. But 345 patients were enrolled from 9 different ICUs in 8 different university hospitals in France. And patients, again, these were traumatic brain injuries, so they had to be comatose with a GCS of 12 or less. They had to be at least 18 years of age or older, and they had to require mechanical ventilation for at least 48 hours. The intervention, so patients were randomized to either get placebo or the intervention was ceftriaxone 2 grams within 12 hours of intubation. And this is a really important thing because you want to obviously give the drug early to see if it makes a difference. And patients didn't receive any special sort of oropharyngeal decontamination. And what they did was they assessed for the presence of ventilator-associated pneumonia within the 2nd to 7th days after intubation. And they used the ATS definition of ventilator-associated pneumonia. So you can see here, 162 patients received ceftriaxone with 157 receiving placebo. And they based the sample size. So anytime you do a study, you do what's called a power analysis to see like how many patients would I need to enroll to see a difference between the groups. And so their sample size was based on a 30% incidence of early onset ventilator-associated pneumonia. We know patients with TBIs often aspirate. And so the hypothesis was that early ceftriaxone 2 grams would cut the incidence of VAP by half. And they, of course, then needed 354 patients to answer that question. The results were actually pretty impressive. So when they looked at early VAP after 7 days, you could see in the placebo group, 32% of patients developed VAP, which is even a little bit higher than they hypothesized, versus only 14% in the group that got ceftriaxone, and that was statistically significant. When they evaluated all ventilator-associated pneumonia within 28 days, you could see there still was a statistically significant difference. So 36% of patients in the placebo group got ventilator-associated pneumonia versus 20% in the ceftriaxone group. The secondary outcomes were also very interesting at day 28. So you could see ventilator-free days. There were 4 more ventilator-free days if you receive ceftriaxone. Antibiotic-free days, so interestingly enough, patients had more antibiotic-free days, 6 more days if they got ceftriaxone, just that 1 dose up front. And then there actually was a mortality difference, which was really interesting as well. And so the absolute risk reduction by giving 1 dose of ceftriaxone up front showed a reduction in mortality. And the number needed to treat, or NNT, is 10 patients, which statistically is really interestingly good in this, especially in this study. So, the intervention was quite simple. It was 1 dose, 2 grams of ceftriaxone within 12 hours of intubation. You could see there were other benefits. So there were more ICU-free days, 6-day reduction if you got ceftriaxone. Hospital-free days, they saw a 15-day reduction if patients got ceftriaxone up front. And then although at day 60, so these are looking at 60-day differences, at day 60 there wasn't a difference in mortality that was statistically significant, but you can see there was definitely a difference. So this is super interesting. I will tell you, this study got a lot of buzz at the Society of Critical Care Medicine meeting. So we'll see. I would love to know in the comments, is anyone starting to see like maybe your EDs or early in the ICU? Are you giving patients ceftriaxone up front prophylactically, and are you seeing a difference? Would love to know your thoughts. And then the question, of course, everybody's got is like, well, if this works for traumatic brain injury, would it work for other patient populations, which I think should definitely be explored.